All right, so I have a special guest today for our recap of Zach's Tuesday times where he's out spending, his CCO hours with members of our team on clinical related conversations. So one of the ones that keeps popping up is related to pre-running plyometrics that are occurring after some kind of post-op situation. So this could be ACL, this could be Achilles, this could be meniscectomy. There could be a wide variety of different situations, all with very different prerequisites that we're not going to dive into today. But generally speaking, what are your considerations with regards to deciding plyometrics are appropriate to start initiating? How are you potentially initiating them? And then where are you taking them prior to also then eventually initiating a running program?
Yeah. So I think anytime you have a lower body post-operative patient, you're looking at what does it look like up until that point. So obviously with an ACL, it's a lot of it's body weight competency and strength training and getting those things back to somewhat baseline. During that process, you're kind of looking at how long can we spend on our feet and tolerate that, not getting reactive symptoms, things like that. So that might occur after 6 to 8 weeks of weight bearing. So around that 2-month mark, you can start looking at, hey, maybe enough time has passed, the symptoms in the knee are kind of quieted down, we can start looking at introducing some low-level impact. Now we know we're probably not going to start running until 3 to 4 months, somewhere in between that time post-op with an ACL. That varies for different surgeries. But what you're going to start looking at is if we're hitting our benchmarks from a strength perspective, like can we isolate the quad with a single leg sit to stand? Can we produce some work through the hamstring? Can our calves also accept force and kind of dissipate that? Then you can start looking at pogos. Now pogos are going to be that static or in place, static positioning wise, maybe with some hand assistance to start, but you're looking to accumulate more reps over a period of weeks. That kind of gives us an idea that we're not going to have any reactive symptoms to impact. Do you want to go into benchmarks for the pogos?
Here's what I'll say.
Yeah.
Something that I do think gets missed a lot of times is we get so laser focused on meniscectomy and ACL that we also forget one of the benchmarks to diving into pogos is also heel raise test.
Yes. Yeah.
So one of the things I'd say, make sure during that 6 to 8 week period is that you're hitting your heel raise test, going into pogos. Then I like how you went into supported pogos. I usually think of stable supported pogos being a great place to start. Countertop, a bench, a box, then transitioning eventually to more of your unstable, right? Or a little bit of variance. With suspension. You could potentially also transition to like using the TRX straps. It's a little bit more firm, but has obviously less give than the band itself. And then obviously you're going to go from 2 legs eventually to 1 leg. Are there any other considerations as you go through that? Maybe something in terms of general dosing parameters? Yeah. Say you have somebody 2 times a week, how might things look?
I think a good place to start is about 3 rounds. We're going to keep it at a 1-to-1 work-rest ratio. So I like to start with 3 rounds, 30 on, 30 off. As you mentioned, maybe 2 legs, working towards 1. And I think if you can accumulate three rounds at 2 legs, you can probably start to introduce the supported single leg version. And as we hit those marks, maybe we can wean away from the support. As you're going, though, the whole point is that you're trying to get progressive overload and how many we're doing. I think starting at 3 is a good place. I think maybe adding 1 round per week so that over that 4 weeks, you're accumulating almost 7 rounds within a session. I think you're kind of just assessing how are we tolerating those things from a symptom reactivity and then just like overall performance. Does it stay consistent throughout? Yeah, go ahead.
Yeah, no, and what we're talking about here is largely more of your short couple, right? It's your short response, very, very low amounts of ground contact time, also less force generated. Right? We're trying to be as reactive and responsive to the ground as possible. Something that I'll be communicating to people after we initially go through what I'll call more complete mode is I'll tell them to take as many hops as possible during a time period so we start to make it a little bit more competitive, right? So that complete to compete mode. Anything you want to add on that?
I was going to say, in a good way to quantify that, and instead of just having to count the reps, which sometimes you have to do, but if you have a metronome on your phone, just setting it, like good benchmarks at 150 beats per minute, so they're getting 75 reps in 30 seconds. If it becomes that they're way below that, you know that maybe we're not quite as conditioned in the calf complex, or as you said, you could start to go into a more competitive of like, can you beat that?
Right.
And now we know what it feels like to do 75 reps in 30 seconds. Let's go faster, let's go harder, all that type of stuff.
Right. And if they're not as conditioned, potentially adding a layer with regards to levels of support.
How do you assist
right?
that?
Yep.
And that's a great way to increase volume. Sometimes I have patients that maybe the calves aren't conditioned as well, and they're just struggling with a lot of calf tightness, a lot of calf pain, something unrelated to why they're coming to you. Right. And adding that suspension is a good way to increase repetition and time spent doing it while keeping the overall intensity to an appropriate level.
And we might do 3 rounds during our one-on-one time, but also add aerobic plyos at some point in time where maybe we're getting to this 5 rounds, maybe pushing up eventually to 10 rounds. And that's when I think of whether or not you're stable supported, maybe having band support or unsupported, where especially from a 2-foot standpoint, we're starting to add in a little variation, right? We've got our stationary with feet. We've got, I always forget what this one's called, where you're going back and forth.
That's several
almost
different
like
names.
a slalom type.
Scissor
Right,
moves?
scissor, yeah,
Jack.
it's probably more it. You got the side to side, you got crisscross applesauce, and then you got the one where you're doing your line hops forward, backward, and side to side.
And those are all building a base for later on locomotive progressions from a change of direction. That's why you're doing that variability. It allows you to stress tissues a little bit differently, kind of builds the blocks for how do we change direction, can we tolerate those things, because all of it's very low amplitude, which is nice, and you get a good idea of how you're dosing that too.
So we talked a lot short response, short coupling, as we mentioned. Now, let's go to the other end of the spectrum. How are we potentially focused on long coupling, long response time, generating more force, also talking about force absorption and dissipation? What are some things that you're thinking about early on when it comes to at least what I think you're going to go into, which is more of getting into position and the absorption and dissipation first before generating power?
Yeah, I think a lot of times you talk about, can we put the brakes on before you start to open the engine up? Right. And if we're talking about the strength speed continuum, we're talking about high amplitude, really powerful movements. So being able to land from a jump first. That might start looking at, or that might begin with snap downs, where we're going from a ground position where we're not leaving the ground, but we're falling into that triple flexion position. Then you could add height to that. That's where you get into the box to ground in terms of depth drops. And again, you're just looking at, like, maybe we start with bilateral symmetrical movements. Then you can add like rear foot supported, and then you can go into like unilateral. Then you start working from a sagittal plane to a frontal to a transverse plane. These are happening over a matter of weeks, but again, we're looking at, can we put the brakes on in multiple positions in multiple planes? So we talked about box to ground. I think the next thing you want to look at is, if we're competent with putting the brakes on, can we hit the accelerator too? And that might start by going from ground to box, which I think Zach has mentioned, we've heard this a lot of times, is when you have somebody jump from the ground to the box, you're taking out the skill and impact associated with landing. So now we get to work on the other phase of a plyometric movement, that force production. Again, ways you can modify that from an intensity standpoint is starting a 6-inch box, 12, the height of the box, but also maybe if you take that to a broad jump type activity, which would be ground to ground. So, yeah, I think that's kind of the progression, right?
Yeah, absolutely. I mean, I like how you broke it up into 2 separate pieces, and then eventually we get towards more of, the end of the GPP spectrum where we're kind of putting everything together. You start talking about your counter movement jumps.
Yes.
You could be in a symmetrical stance. You could be in an asymmetrical stance. You could be in single leg stance.
Externally loaded.
Yep. Yeah. Yep. And maybe you're potentially at some point, creating an isometric at the bottom of the loading phase before somebody produces force. So there's a lot of different directions to go in, but hopefully this video today provided a full picture of the spectrum of plyometric activity that you're considering before jumping back into running. And you have a little bit better idea of some of the things that you should be focusing on with somebody who is post-op and eventually going to be running. As Greg mentioned, I do think it's important to just close with, you have very, very different timelines of expectations. He did mention ACL in that 3 to 4 month mark. A meniscectomy is probably going to be earlier, and you're probably going to have an Achilles be later, because there's going to be certain things you have to make sure that you're considering with regards to range of motion and some of those isolated prerequisites. But hopefully this was beneficial.